You're listening to Medscape's In Discussion series on bipolar disorder, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Trisha Suppes. Dr. Suppes is a professor of psychiatry and behavioral sciences and the director of Exploratory Therapeutics Laboratory at Stanford University School of Medicine. She also serves at the Palo Alto VA as director of the Cooperative Studies Program Network of dedicated enrollment sites and a staff physician. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I am Trisha Suppes, and welcome to Medscape in Discussion Bipolar Disorder podcast series. Today we'll be discussing bipolar disorder and substance use disorders. It's an important topic because the number of folks with bipolar disorder that have substance use disorders is very substantial. Let me introduce my guest, Dr. Michael Ostacher. Dr. Ostacher is a professor of psychiatry and behavioral sciences at Stanford University. He is also site director of the Addiction Medicine Fellowship at the VA Palo Alto Healthcare System, where he also serves as medical director of the Pharmacology of Addiction Recovery Clinic. He also is the director of the Bipolar and Depression Research Program and co-director of the VA and Stanford Exploratory Therapeutics Lab. Welcome to In Discussion. So, Michael, it's great to see you. First, I'd just like to ask you, how often do you think we see substance use disorders or substance use in folks with bipolar disorder?
My goodness, this is such a important and interesting question. Thanks for inviting me to this discussion. It's really hard to pin it down because it really depends on where you're sitting. As you know, prisons have become a kind of de facto state hospital, especially in certain states where resources aren't great. And my guess is that if you're treating patients as a psychiatrist in a state hospital someplace or a prison someplace in the United States, they have bipolar disorder, there's probably 100% chance that those people have a substance use disorder at the time they came in. So if you're working in a forensic setting and you're seeing people with very severe mania and psychotic mania whose behavior leads them to do things that get them arrested, it's almost certain those people have a significant history of substance use, recent substance use, or even time that they're arrested. If you're working in a bipolar specialty clinic, where I worked for many years, and I know you've worked in longitudinal study too, and in clinics that treat people with bipolar disorder, much less likely to see active substance use disorder in that population. And so it really depends on where you sit. If you're working in emergency services, for example, there's a high likelihood that the people who come in acutely ill, whether it's with depression or mania, who have bipolar disorder, will have substance use complicating their condition. But people who are stable in treatment tend to have substance use disorders that are well in their past.
That's great. Do you differentiate in your thinking between different substances regarding bipolar disorder? For example, alcohol, cannabis, nicotine, opiates, and psychedelics, just to name a few.
That's a really interesting question. I mean, I think that probably you can just go in the order of popularity of drugs in the culture in which we live, right? So the most likely substance that people are using at a certain point in their lives, if they have bipolar disorder, is alcohol, or at least the substances that we're discussing today. And one of the substances that we've left out is tobacco or nicotine. I think it's worth having a discussion later about that. But I think probably alcohol is likely the biggest drug that gets used by people who have bipolar disorder, followed by cannabis after that. And then, as is true in the general population, the use of other drugs like stimulants, including cocaine and methamphetamine, or drugs like opiates, are much less likely to be problematic in people with bipolar disorder. Now, that said, it really depends on the setting in which you're seeing people. So if you're seeing people in inpatient addiction treatment services, you're much more likely to see people with stimulant use disorders or opiate use disorders or alcohol than you would be in other settings.
So given your focus on the setting amplifying how many people are using substances with bipolar disorder, what's your view of the overall population with bipolar disorder, which is conservatively about 1% of the population in terms of substance use?
I think it's important to divide it into lifetime versus current substance use disorders. So it's well known, and I think it's probably reasonable to accept that somewhere between 45 and 70% of people, certainly in the United States, who have a diagnosis of bipolar disorder will have at some point in their lifetime met the criteria for a substance use disorder. And so half, at least, probably in general practice, will people have a lifetime history of substance use disorder. Those substance use disorders tend to occur when people are younger. And so people tend to have more problems with drugs and alcohol when they're early in their course of illness. Most of us who treat people with bipolar disorder treat people who are much older, and those people tend to have had substance use disorders in their past. And so lifetime prevalence is really, really high in bipolar disorder. This is true for all psychiatric illnesses, though. The rates are really quite high. So for anxiety disorders, depression, PTSD, those disorders also have high rates of substance use disorders, but for bipolar disorder, it's probably higher than for all the rest, perhaps excluding schizophrenia. But if you look at people who are in treatment, the likelihood that they're going to have a substance use disorder complicating their treatment at the time that they're pursuing treatment for their mood disorder, for their bipolar disorder, is much, much lower. And so it's likely only a quarter of those people, so roughly 10 or 12% of the people seeking treatment for bipolar disorder will have substance use disorders currently at the time they're seeking treatment that require attention from us.
Well, related to that, substance abuse usually means people are not having good fidelity taking their meds. But do you think substance abuse itself can worsen the course of bipolar disorder?
That's certainly true, but this is a really complicated thing to think about from a lifespan perspective. The people who have substance use disorders often have more difficult courses of illness and less functioning in their lives, right? So they'll have more suicide attempts and more episodes and more hospitalization, and will have more difficulty keeping jobs and relationships and have lower life satisfaction. And those things are all true. The question is whether or not the substance use is causal, in other words, leads to having those problems, or whether the people who have more severe bipolar disorder end up having substance use disorders also. I don't know whether it would fit under the rubric of self-medication, for example, but it might well be that people who have more severe bipolar disorder are just more prone to using substances.
Could it also just be when folks are using substances, they're also not compliant with their medicines, which can in and of itself worsen the course of illness, more suicide, more episodes? Do you view that as a factor, or is that not the case?
It's certainly true. Well, if you think about working with people long-term with bipolar disorder, one of the main things that we try to help people do is take care of themselves in their lives, have stable relationships, have a stable place to live, take care of their medical conditions, make sure that they have adequate income and housing, other factors that are associated with things. And people who are not doing well tend to have all these problems, including substance use disorders. That people who have substance use disorders are less likely to take their medications, may be related to their substance use disorders, may be related in general to their lack of ability to take care of themselves. It's completely true that people who have substance use disorders and have bipolar disorder have less adherence to their medications, are more likely to stop them, and more likely, of course, if they do stop them, to have negative effects from that, relapses, recurrences, continued symptoms over time.
So I feel like what you're saying is that we really can't tease the causal aspect apart. We don't know what's the chicken and the egg. So a lot of people with bipolar disorder at some point in their lives have substance use disorders. Whether that worsens the course or the fact that they're doing it reflects a worse course, we don't actually know that.
Yeah, I think that uncertainty is unfortunately there. One of the things that people conclude because of people's substance use is that they themselves are worsening their condition because of it. And it becomes very frustrating for providers to think about treating people who have substance use disorders because they anticipate they won't do very well with treatment. It turns out that it's probably not the case. It's probably not the case that people who have substance use disorders actually do worse once they're in treatment with you. Epidemiologically, they certainly do. But it may also be the case that when people get engaged in treatment and they have an opportunity to address both their bipolar disorder and their substance use disorders, that they may actually have a better course of illness than people who don't have substance use disorders. It may seem paradoxical that this would be the case, because you would think, oh, people have two disorders, they've got to be worse, their substance use leads them to have all these negative behaviors. But if people are seeking treatment, they tend to be moving towards a place of wellness, in my experience. And the data suggests people who have substance use disorders at the time they enter treatment, they may have shorter episodes of both depression and mania and fewer relapses in treatment, partly because their symptoms that brought them into treatment may have been worsened by their substance use. If they back off on their substance use, if they stop using substances, if they drink less, they're using substances, drugs less, they may have a better outcome than other people.
That's really interesting. Well, that brings me to this old idea, which I don't think is a current one, so I'm interested in your perspective on this. So the old idea was you needed to treat the substance abuse before you address bipolar disorder symptoms. What is your current thinking on this?
Well, that would be old thinking. I do think that, unfortunately, in psychiatry, we tend to think of substance use disorders as other people's problems to take care of. And I think that's quite unfortunate. We have specialty treaters in addiction. We have subspecialization, both in addiction psychiatry and addiction medicine, that people can pursue. Most people do not pursue that. There are very few people who are certified in that. But it would benefit our patients if we had a little bit more comfort with helping people address their substance use disorders.
That's a great point. So what is the current thinking about when you have the co-occurring substance abuse and active bipolar symptoms, that you address them together?
Well, the reason I raise the concern in our field is that people tend to think, well, I can't deal with the substance use. It's going to get in the way of my treatment. Let me send them someplace else to get their substance use disorder treated. And I'm not sure that it's the most effective way to treat people. It ends up being kind of paradoxical. People tend to expect that people need to go get their substance use disorder treated first. I think with illnesses like bipolar disorder, you certainly have to address people's bipolar disorder up front. The outcomes for people are really terrible if they don't have treatment, and it's much in our interest and in the patient's interest and the interest of people's families that they get their bipolar disorder treated. Whether or not you address substance use disorders, whether you refer them on at the same time, is something that I think about a lot. And of course, I'm interested in both, so I treat people simultaneously. That leads me to raise another question, if that's okay. And that's the question of whether or not we need to study the treatment of substance use disorders in people with bipolar disorders separately from the study of people who have substance use disorders without bipolar disorder.
That's a very interesting question. I'd be curious of your perspective on that, because that's not a way that people thought previously, but I've been hearing more about that as an approach. What is your view on that?
When I first started doing research in bipolar disorder, my interest was in studying people with bipolar disorder who had specific substance use disorders, thinking that because people with bipolar disorder so often are excluded from trials, both of medications and treatments for substance use disorders, and people with substance use disorders being excluded from studies of bipolar disorder, that we needed to study these specific populations. But the devastating outcomes for substance use disorders in people who have mental illnesses are so grave that it's probably important that we skip that step. Would it be, in an ideal world, something that we would address together? In other words, should we study, for example, whether or not people with bipolar disorder who are given medical treatments for alcohol use disorder do as well as people who don't? Yeah, I think in an ideal world it would be nice to do so, but I think we've gotten to the point where our understanding of the treatment of substance use disorders with medications, for example, the use of naltrexone, an opiate blocker for alcohol use disorder, or a camprosate, evidence-based treatment for alcohol use disorder, should we withhold those drugs from people who have bipolar disorder? I would say probably not. I think we should treat them ahead. And I mentioned smoking earlier. Even more important, if people smoke cigarettes, the life expectancy of people who have bipolar disorder is clearly shortened compared to the general population, probably shortened compared to most other mental illnesses other than perhaps schizophrenia. And one of the things that we can do to help people have less morbidity and mortality is to get them to quit smoking. Should we study smoking cessation completely separately in populations with bipolar disorder? I don't think we can wait to do that. I think we need to use the tools that we have at our disposal and use them in bipolar disorder. In fact, drugs like varenicline, which is nicotinic acetylcholine receptor agonist and partial agonist, depending on the different receptor subtypes, is remarkably effective at helping people quit smoking and is remarkably effective in helping people quit smoking of bipolar disorder.
You're talking about smoking, but how about vaping, which is very common, more so than smoking these days, so to speak? And what's your view on vaping? High-dose nicotine, you're inhaling. Do you view it as having similar detrimental physiological impact?
Oh, that's a really interesting and important question. So this raises the question of whether or not harm reduction approaches in smoking cessation and tobacco use cessation are reasonable approaches. Here in the United States, we've not adopted them yet. And so in the United States, we do not have any formal approvals for the use of electronic nicotine delivery system ends, of which vaping is the kind. We do not have any approval for that. However, in the UK, for example, it's very clear that they've adopted the use of vaping, of electronic cigarettes, as a means for reducing smoking in adults there. We have a different regulatory system here, but they've decided that getting people off of combustible tobacco, in which they are inhaling clearly carcinogenic compounds and carbon monoxide, and engaging in a behavior that's clearly associated with terrible outcomes for multiple organ systems, including malignancies and lung disease and cardiovascular and cerebrovascular diseases. They've decided that the risk of vaping is so much lower that they are willing to spend money to get people to switch from cigarettes to vaping devices.
You would view vaping as a lower physiological harm reduction approach?
Yeah, I mean, I think the evidence is pretty strong that the risk of one is not comparable to the risk of the other. Are the risks of vaping devices well known? Not 100%. No, I mean, I think there's a certain amount of uncertainty about whether or not there are long-term harms from vaping devices. But at this point, it's pretty clear that their risks are much lower. And then you're asking the question, is high-dose nicotine a problem for people? And I don't have a good answer for that. I think what they've decided in the UK is, unlike in the United States, where the recommendations always for smoking cessation always are initiate a smoking cessation treatment, stop smoking, set a quit date, stop smoking cigarettes, stay on the treatment, whether it's varenicline or nicotine replacement or bupropion, and then stop those drugs after several months and be both without drugs and without smoking. In the UK, they have a different approach. They literally replace people's tobacco use with electronic cigarettes. The goal is not to stop using nicotine. The goal is to stop inhaling combustible tobacco.
So I know there's been some recent concerns about what they put in the vaping and that can be damaging. So it's sort of like a sidebar about vaping.
Yeah, I mean, I think it's reasonable to go there, especially because the rates of smoking in bipolar disorder are so high. There was a concern several years ago that vaping devices, which are not very well regulated in the United States. In fact, the FDA, which had made a determination that they would regulate vaping devices, put off those regulations for 5 years. I think this was in 2017. And when they made that determination, there was a wild west here of vaping devices. So people are making their own, what do they call it in the vernacular, vape juice. There was a crisis of lung injury and some death in the United States that ultimately were thought to be due to one of the constituents in some vaping devices. These were primarily in cannabis vaping devices, but existed in some nicotine vaping devices. And that chemical has been removed. This really happened because of the failure of our regulatory system to determine that they were safe prior to their hitting the market.
So that's very interesting. Before we close, I want to come back to something you mentioned a few minutes ago, which is this concept of harm reduction 15 years ago, nobody was talking about harm reduction. But now, particularly, I'd be curious about some of your perspective on the opioid crisis, which is very real and impacting lots of people with or without bipolar disorder, in which the concept of harm reduction has really taken center stage.
I think it's important to consider harm reduction from a philosophical perspective and also from a practical perspective. So the idea of harm reduction is that you reduce the harm that people who are using substances might have by changing something in their behavioral pathway. So the best example of harm reduction in the drug use world would be clean needle, so needle exchange. And so the goal of giving people clean needles is to prevent transmission of infectious diseases, mostly hepatitis C and HIV. And they're very effective at doing that. They don't do anything to help people stop using drugs. They just help people stop having harm from drugs. And the question is whether or not we should be, as a society, in a place where we're not moving people towards stopping using. And that's a question for which I don't have an answer. Society needs to answer that question. When it comes to the health of my patients, I would lean towards the harm reduction approach for people who are in care with me. And so getting people to use less dangerous nicotine devices, for example, it's very clear that as a nicotine delivery device, cigarettes are terrible. It's pretty clear that vaping devices are less difficult. And this goes back to what we talked about at the beginning. There's very clear treatments for opiate use disorder. The main two medications that we use are methadone and buprenorphine. People can also use naltrexone injection to treat people who have opiate use disorder. I don't think we need to study whether or not those drugs work in bipolar disorder. The consequences of opiate use disorder in 2024 are so dire. The drug supply is so tainted in the United States that the likelihood that people will be using fentanyl and die accidentally of a fentanyl overdose is extremely high. 100,000 people in the United States died of drug overdoses last year. It's the third year in a row. 70,000 people died of opiate overdoses. A harm reduction approach, one that gets people onto one of those medications, into treatment, is a really important task for those of us in psychiatry.
Thank you so much. So I just want to wrap up and say today we've talked to Dr. Ostacher about, to me, one of the most interesting perspectives is in terms of harm reduction, not waiting to study substance use in bipolar disorder. But if we have validated treatments for substance use, we should go ahead and be open to using them in bipolar disorder. I thought the perspective was also very interesting that how much you're going to see substance abuse in bipolar disorder in part depends on the lens through which you're looking. So in jails and hospitals, you're going to see very high, maybe even in the ER, but in longitudinal outpatient clinics for bipolar disorder, you're likely to see less. Thank you very much. For me, this has also been very educational. I think the thinking is changing. So thank you for tuning in. Please take a moment to download the Medscape app if you'd like to listen. Subscribe to this pod series on bipolar disorder. It's also available on all of your favorite platforms. This is Dr. Trisha Suppes for the Medscape in Discussion Bipolar Disorder podcast. Thank you for joining.
Thanks for listening to Medscape's In Discussion Bipolar Disorder podcast series with our host, Dr. Trisha Suppes. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on bipolar disorder.